Hello, this is Dr. Dancea. I'm presenting a talk on finger dislocation. I'm a hand surgeon at Cardio and Clinic Orthopedics in Roanoke, Virginia. As an outline, we're going to be talking about hand joints, MCP joints, PIP and DIP joint, fracture and dislocation. And we're going to touch briefly on anatomy, treatment, and outcomes after treatment. First, I would like to start with the most proximal of the three joints, the MCP joint. Talk about anatomy. The head of the metacarpal as well as the base of the proximal phalanx are wider on the volar aspect of the joint, which does create an increased joint contact and implicit increased stability with MP joint flexion. I would like to describe such a joint like a box concept with collateral ligaments on both sides, the lateral sides, and the thick volar capsule and slightly thinner dorsal capsule forming the roof and the floor of the box. The true collateral ligaments have a more horizontal tract going from the head of the metacarpal up to the relatively volar half of the base of the proximal phalanx, while the accessory collateral ligament starts slightly palmar to the proper collateral ligament. But as you see in the graphic on the right, it ends up essentially on the volar plate. Because of this position, the true collateral ligament and the dorsal capsule are tight or taut in flexion, while the accessory collateral ligament and the volar plate are tauter in extension. Again, talking about anatomy, the deep transverse intermetacarpal ligament connects the volar plates of the index through small finger, where it attaches palmarly and deep to the A1 pulley. This ligament gives stability in coronal and axial planes to the hand. Talk about injuries now. Dorsal metacarpal joint dislocation are more common than volar dislocation, although in general MP joint dislocations are relatively rare. The border fingers, index and small fingers are slightly more frequent, and we should be looking for associated DIP joint dislocation as well. Clinically, we observe palmar skin puckering over the MP joint, again in the palm, at the level of the distal palmar flexion crease. The mechanism of such an injury is usually a forceful hyperextension, either during a fall or during impact to a ball or a harder object. Injured structures that could be blocking the reduction could be volar plate, A1 pulley, or flexor tendons, as well as the lumbricals. An important thing to remember is that in dorsal dislocation of the MP joint, the volar plate remains mostly attached to the proximal phalanx and ruptures off the head of the metacarpal. It's exactly opposite on volar dislocation. But again, dorsal dislocations are more common for the MP joints. Volar plate ruptures proximally, as I said, off the head of the metacarpal and frequently interposes dorsally between the metacarpal head and the proximal phalanx. The flexor tendons are drawn dorsally, and because of that, they tighten with traction, and that has implications in how we reduce such fractures. We'll talk about that when we talk about the reduction. For the index finger, the metacarpal head gets entrapped between the flexor tendons to the index finger ulnarly. You have to think how they're coming from the center of the palm and then head toward each finger. So both FDP and FDS tendon to the index finger will remain ulnarly, but lumbrical will sit radially, and that's where the head of the metacarpal gets entrapped. Radial digital nerve to the index finger, which sits right superficial to the lumbrical, will become extremely superficial. It's going to be right in the palm, under the skin, and could be at risk in case of a open repair, as the nerve is going to be very superficial, or also it could be entrapped with reduction. For the small finger, the head of the metacarpal gets entrapped between some of the hypotenar muscles, abductor digiti minimi and flexor digiti minimi ulnarly, and we'll have the flexor tendons, both flexor tendons to the small finger and lumbricals radially. For simple MP joint dislocations, the proximal phalanx is essentially locked in hyperextension around 60 to 80 degrees. If we try to reduce them with simple traction, that usually it's not efficient, won't result in reduction. Will be necessary to start with wrist flexion to relax the flexor tendons, then apply a gentle MP joint extension, and at the same time volarly directed pressure on the base of the proximal phalanx, as in the picture on the right, and then gently flex the proximal phalanx while pressing in a dorsal to volar direction. This usually results in a reduction of the dislocation unless the interposition of other tissues. Dorsal extension blocking splinting and early range of motions are a usual treatment. I would splint in resting position with about 10 to 15 degrees flexion and allow full motion at the PIP and DIP joints. For complex dislocations, the MP joint, which are more common in children, where is a high risk for avascular necrosis of the head of the metacarpal and physical arrest. In general, we have interposed soft tissue within the joint that does not allow closed reduction. An X-ray may show a sesamoid interposition, which suggests that we have entrapped volar plate. Or we could have metacarpal head fractures. A special view to better diagnose a metacarpal head fracture, like Brewerton view, could be necessary to visualize all the aspects of the injury. For if we're in such an irreducible MP joint dislocation, we need to proceed with open reduction. In case that we choose the dorsal approach, we incise the capsule longitudinally, and that will allow visualization of the volar plate, which can be divided and then reduced palmarly where it belongs. If needed, we could repair a metacarpal head fracture through this approach very easily, as it gives us a good visualization of the entire metacarpal head. When we choose to approach this volarly, for the index finger, we should be cognizant, as I mentioned, of the potential damage to the radial digital nerve to the index finger, which could be right subcutaneous or immediately under the skin. Will be necessary to release the A1 pulleys that would decrease the tension of the flexor tendons and allow reduction. The proximal phalanx and the volar plate get then reduced palmarly. Again, volar plate can be split if needed to allow reduction, then repaired after the reduction. The volar MP joint dislocations are much more rare. And as I mentioned, the MP joint dislocation are rare anyway. Offending anatomic structures that may prevent reduction in this case is the dorsal capsule, which does a rupture of the metacarpal head, similar to the volar plate in dorsal dislocations, but we have to be careful, and that's testable material for residents. The distal insertion of the volar plate ruptures off the base of the metacarpal, while with dorsal dislocation it's exactly opposite. The volar plate ruptures off the head of the metacarpal. Distal collateral insertion may also be interposed in the dislocation site and prevent reduction, as well as junctura tendinous for the border digits. Treatment, I would start with closed reduction if possible, and if not, proceed with open reduction through the dorsal approach. Moving distally to the PIP joint, anatomy, it's not far from the MP joint. We have the same box concept with collateral ligaments laterally and the volar and the dorsal capsule creating the floor and roof of the box. It's a bicondylar hinge joint with two condyles on the proximal phalanx, and of course the base of the middle phalanx being concave. Similar to the MP joint, the proper collateral ligaments and the dorsal capsule are tight in flexion, while the accessory collateral ligament and the volar plate are tight in extension. If the true collateral ligament is intact, that being said, if the injury is volar to the insertion of the true collateral ligament, even if it involves a small fragment of bone or it's a pure soft tissue rupture, the injury will be in general stable, and after reduction, the joint will remain stable. A dorsal injury, there's a dorsal translation of the fragment, and it may be described as a jammed finger. To remember that if the volar plate avulsion may result in flexion contracture as it's healing, as the volar plate is extremely thick and may form thicker scar. When we talk about PIP joint dislocations, again, we have frequently a dorsal migration of the shaft of the middle phalanx with dorsal dislocation. It is stable if the proper collateral ligament remains on the shaft and becomes unstable if the proper collateral ligament is attached to the volar fractured fragment. Because of that, in general, if the fracture involves less than 40% of the base of the middle phalanx, the fracture will be more stable, as some of the proper collateral ligament will remain attached on the main shaft of the middle phalanx. But if it's more than 40 to 50% of the articular surface that's involved, then always the proper collateral ligament will be attached to the fractured fragment, and the dislocation will be unstable. Imaging, it's important to get regular x-rays with good PA and lateral views. We assess for joint congruency. Irreducible dislocations will often show a V sign, which suggests that there's interposed tissue between the two bones. Treatment, I would always start with attempted closed reduction, and if that's not possible, consider open reduction, either through a dorsal approach, when the capsule will be incised between the central slip and the lateral bands, and that would allow visualization of the joint and the displaced volar plate, which could be pushed palmarly in its normal position, and the dislocation can be reduced. Also, this can be approached to a volar approach when we incise and completely excise the A3 pulley, retract the flexor tendons, and then extract the volar plate from within the bone fragments and then repair it to its attachment. A bit more common dorsal dislocations of the PIP joints are caused by a hyperextension injury that stresses the volar plate and collateral ligaments. Volar plate tends to shear off the base of the middle phalanx. A nice way to remember that, in general, the volar plate tends to stay with the proximal phalanx in both MP joint dorsal dislocations, which are more common, and also in PIP joint dorsal dislocations. In palmar dislocations at the PIP joint, in general, we have an injury to the central slip of the extensor tendon. You can see in the graph there, it's often a complete disruption of the central slip, with the lateral bands of the extensor tendon remaining intact but spreading apart. We also can have lateral PIP joint dislocations when we have an isolated injury to one of the collateral ligaments, which could also include that part of the volar plate. Treatment goals is to restore joint stability with concentric reduction. We want to see an equal joint thickness on a lateral X-ray after reduction. It's important to reestablish full motion, smooth gliding motion. It's important to control edema prevent excessive swelling and allow early motion, as the PIP joint gets stiff extremely quickly with immobilization. For the more common dorsal PIP joint dislocations, again, the injury usually it's, as I mentioned, the PIP joint hyperextension with axial load, and could result in a minor injury just to volar plate and axillary collateral ligament when it's essentially a subluxation, not a complete dislocation. Um, uh, Moving into type 2, where when the axillary collateral ligament gets involved. In a type 3, essentially a fracture dislocation that could involve more or less of the volar lip. If it's more than 50%, it's unstable. If it's less than 40%, it's considered stable. 40 to 50%, it's somehow gray area, where some fractures are stable, some others are unstable. Treatment, again, the goal is similar to MP joint, to give good stability. We'll start with closed reduction, and after reduction, we'll check collateral ligament stability. If that remains stable and joint does not redislocate, body taping to an adjacent finger, and extension blocking splint in slight flexion. In general, 20 degrees are sufficient, but rule of thumb is to splint in 10 degrees more than the angle where the joint is losing its stability. The splint should remain placed for 2 to 3 weeks, and then patient will be allowed to further progress with further extension. From the position in which the PIP joint is splinted, the patient should work on flexing the PIP joint up to maximal flexion, and that should be started early on. Main complication of closed treatment, as it is for all the types of treatment for the PIP joint, is stiffness. A different mechanism is twisting injury to the flexed PIP joint, which could result in a lateral instability. I mentioned those types of treatment. Closed reduction, it's a treatment to go, and for volar PIP joint dislocation, it's important to test for presence or integrity of the central slip, and Elson test is used for this. It's a very good clinical tool to assess for central slip integrity. If central slip is injured, the PIP joint should be splinted in full extension for about 4 to 6 weeks to prevent boutonniere deformity. Open reduction internal fixation is appropriate if there's a larger fragment, and this can be stabilized. We could use pins versus screws to stabilize the fragment. In cases of lateral PIP joint dislocation, closed reduction body taping is in general indicated and often successful. Again, early range of motion is indicated to avoid stiffness. Surgical repair, it's in general indicated in patients that desire to return to full use and full motion sooner, like athletes. But in general, non-operative treatment is better and results in less stiffness of the PIP joint. Fracture dislocations of the PIP joint could involve the dorsal lip, the volar lip, as I mentioned earlier, or both of them, and essentially entire joint surface. Pilon fracture, which is essentially unstable. Treatment guidelines differ depending on the amount of fractured bone. In volar lip fractures, in general, less than 30, if that involves less than 30 degrees of the articular surface, the fracture is considered stable, and the finger can be reduced in full extension. Tenuous is with between 30 to 50 degrees when some joints remain stable, some others redislocate, while if the volar fragment, it's more than 50%. By definition, the fracture will be unstable, and it will require more than 30 degrees of flexion to maintain reduction. For the dorsal lip fracture, they are stable in general when the fracture involves less than 50% of the joint, and if it can be reduced in full extension. If the fracture cannot be reduced in full extension, in that case, it's considered unstable, regardless of the amount of involvement of the articular surface. All pilon fractures are essentially unstable due to significant articular involvement. For the dorsal lip fractures, in general, it happens with injury in hyperflexion and axial loading in hyperflexion, and then the head of the proximal phalanx is impacting the dorsal lip of the middle phalanx. In general, if it's less than 25% of the articular surface involved, the treatment it's non-operative with splinting and full extension for up to 6 weeks while allowing a DIP joint motion. If there is more than 25% of the articular surface involved, then open reduction versus percutaneous pinning are recommended to reduce the fragment and restore the articular surface. For volar lip fractures, those are much more fractures. Those are much more common. We discussed it a few times before. It's very important to remember those numbers. Up to 15-20 degrees, those are stable. In between 30 and 50 degrees are considered tenuous and could go either way, could be stable versus unstable. When the fracture involves more than 50% of the joint, it is always unstable. And that depends on where the proper collateral ligament inserts on the base of the middle phalanx. It's important to evaluate those fractures with through lateral X-ray for patients where we have concentric reduction with no subluxation through motion, again, no V sign, early range of motion, and body taping to adjacent finger. It's recommended, even if the fragment is slightly larger. If there is subluxation, we have to use fluoroscopy to determine if the joint has reduced appropriately, and the joint is considered stable. Again, if it's less than 20% of the base of the middle phalanx involved, and if the PIP joint is reduced in less than 30 degrees of flexion. Treatment options for fracture, these volar lip fracture dislocations are extension blocking splint, extension blocking pinning, which is a percutaneous pin, dynamic external fixator, and there's a number of frames that have been described, open reduction with screws or pins, hemihamate arthroplasty, and volar plate arthroplasty, which are usually reserved for more chronic subacute cases or a combination of the above treatments. For a type 3A, which is in general a relatively stable fracture, less than 40%. Again, it's a fracture. Type 3, it's a fracture dislocation. A means it's less than 40% of the articular surface. Extension blocking splint, as in the picture on the right, is acceptable. We need to obtain X-rays to confirm reduction, and if this is confirmed, we can continue non-op treatment, and we can continue to extend with roughly 10 to 15 degrees per week until we achieve full extension. Most patients get to essentially 90 degrees of arc of motion at the PIP joint, with one known complication being a slight extensor lag of up to 10 to 15 degrees. Extension pinning, basically, it's the next treatment. If the fragment is relatively large, more than 40%, the fragment could be reduced percutaneously and the pin could be placed, and an additional pin can be placed in the head of the proximal phalanx, creating a barrier to extension. The principle is about the same. Will allow about 20 to 30 degrees of extension blocking at the beginning and advance as the healing continues. complications are stiffness and pin site infection. Results are relatively similar to dorsal blocking splint, around 84 degrees for range of motion, arc of range of motion, which is reasonable. There's a number of frames that have this described, like external fixation, dynamic traction, force coupling devices, and those all work well through traction and ligamentautaxis that counterbalance the deforming forces in the joint. Rubber bands will apply traction, offloading the articular surface and allowing reduction, but we still need a dorsal lip that's intact to which the volar fragment can be brought to. The complications go up to about 30%, infection at the pin site, loosening of the pins, which require revision. When we have larger fragment, open reduction internal fixation could be attempted. That would be through a volar approach. We could use screws or small plates. That has the big advantage of permitting early range of motion, but again, complication are stiffness and possible loss of reduction if the fixation is not appropriate. Results are similar to the previous methods with arc of motion around 85 degrees if it's only one fragment, which decreases significantly to about 65 degrees if there's multiple fragments. One complication, like in the other methods, it's flexion contracture up to 14 degrees. Volar plate arthroplasty, it's usually used for injuries where the injury happened longer ago. It's like a subacute or chronic injury, and an injury that involves 30 to 50% of the joint surface. The bone fragment attached to the volar plate distally is excised, and the volar plate is advanced into the space left by excising the fragment and could be attached with anchors or through a button like in the picture on the right. If we try to do this in somebody with where the fractured fragment involves more than 50% of the joint, in general, it's not successful, and this results in a redislocation. One complication that is common, it's flexion contracture due to thickening and scarring of the volar plate. Hemihamate arthroplasty has been described for the past couple of decades. In general, it's indicated when more than 50% of the articular surface is involved. Chronic dislocations where the bone is not a good quality anymore. The dorsal lip of the hamate, which anatomically resembles the volar lip of the middle phalanx, does provide a volar buttress to dislocation. In general, results are good with a range of motion, arc of range of motion around 70 degrees in both acute and subacute patients. Some patients required further treatment, including revision to silicone arthroplasty. Different studies show relatively close results, arc of motion up to 80 degrees, but we have to note that complications can happen in up to 1/3 of the patients with flexion contracture in at least 10% of the patients, and radiographic DGD in up to half of the patients if they're followed long enough. The donor site morbidities are in general minor and considered not significant. It is a reliable technique for acute and chronic PIP joint fracture dislocation. Again, if the volar fracture involves more than 50% of the articular surface. Pilon fractures are by definition stable. They would need better reduction, but has been shown that the exact anatomic reduction of the joint is less important than actually institution of early motion, such that splinting and traction with different frames have resulted in similar results with open fixation with actually less complication. Moving distally to DIP joint, the probably most common condition resulting in dislocation or refractive dislocation is a mallet deformity, which could involve the extensor tendon or also the dorsal lip of the distal phalanx. The mechanism is a forced flexion of the fingertip that can happen with any daily activity or sports, or could be an open laceration versus a crush or abrasion injury. Presentation is usual deformity, difficulty extending the finger, actually inability to extend the finger actively, and an extensor lag. Most commonly affects the middle finger, followed by the small finger, and then the ring finger. The Doyle classification classify those in closed and open injuries, and also based on bone involvement. They are called acute when they're less than a month, less than 4 weeks, and chronic more than 4 weeks. Returning to the Doyle classification, type 1 is closed injury with or without a small dorsal avulsion fracture. Type 2, it's a laceration, clear laceration. Type 3, it's an abrasion injury. And in general, for those, exploration and direct repair, it's indicated, while type 4, it's a mallet fracture. 4A would be a distal phalanx physial injury in a pediatric patient. Type 4B would be a fracture fragment involving in between 20 to 50% of the articular surface, which happens in adult, and 4C would be a fracture fragment involving more than 50% of the articular surface. Here is to note that if the fragment involves less than 20% of the articular surface, that would be a type 1 injury. Again, type 1 treatment, non-op, it's the most common treatment. Has been shown that the position of the DIP joint alone dictates the gap that forms in a healing area of the terminal tendon, irrespective, again, independent of the PIP joint. And also, it's important to remember that lengthening the terminal tendon with 1 millimeter results in 25 degrees extension lag. Treatment is non-surgical with the stack splint, giving good results. There's slight extension deficit with such treatment, but usually it's around 10 degrees and results in excellent patient satisfaction with very little functional impairment. Type 2 and 3, as I mentioned, being open injuries, are addressed through debridement and direct repair. Moving to type 4, we can try splinting or casting versus pin fixation and open reduction. Type 4A, and this is very important not to be missed. It's a transepiphyseal Salter-Harris fracture called Seymour fracture. Does require exploration, relatively urgent exploration of the fracture with reduction of the physis and reduction of the interposed nail bed, which has to be extracted from within the fracture and reduced in its anatomic location. After reduction, we could splint or we can pin the distal phalanx as needed. It's very important not to be missed because it results in high risk for infection if missed. Type B and C, which involve more or less of the articular surface. In general, non-operative treatment could be successful. Splinting on casting, including stack splint, could be attempted, and if it results in good reduction of the fracture, treatment can be continued non-operatively. In general, is good reduction, even if there is slight subluxation within the splint. Other options are surgical treatment, like operative treatment with closed reduction and percutaneous fixation versus open reduction, which has been shown to have no significant advantage in the final results, but being open treatment have increased complication. All patients would tend to develop a lump on the dorsal aspect of the DIP joint, both operative and non-operative treatment. Patients that had non-operative treatment of the most common complication would be skin issues like erythema or slight discomfort. Those complications are common up to half of the patients, but they are transient. While in operative and surgical treatments, again, we talk about 50% complication rates, but those could be more significant, like joint incongruity resulting in pain, nail deformity, and also need for reoperation.